Thank you to PK and the organizing committee for inviting me, and Dr. Matthews for giving half my talk for me. So kind of proved a lot of things I have to say on this. But like Dr. Schneider, I do have to admit that probably about half my common femoral interventions are endovascular. Not necessarily in a 64-year-old, though, which is getting younger and younger as I get older and older. Here are my disclosures. Endarterectomy, this is the gold standard that we have to really compare all our interventions to. I'm not saying that's the only way you can do it, but you have to say what else are our options as you go through. And I look at it as endarterectomy. I already mentioned the hybrid approach to endarterectomy, and then dealing with iliacs or SFA at the same time, endovascular in a hybrid suite, and then the endovascular options that were already thoroughly discussed. Kang et al. From the Mass General group presented the role of femoral endarterectomy, a common femoral endarterectomy alone in a series from 2002 to 2005, and they showed that they had a 5% major complication rate, hematoma, wound infection, thrombosis, and a 9% overall minor complication, which is superficial wound infections or lymph leak, no mortality. And then they had 1 and 5 year data with patency of 93 and 91%, and in secondary patency or primary assisted patency of 100% at 5 years. So when you're looking at this data, we're not looking at 6-month data, we're not looking at 1 year data, we're looking at 5 and longer data. So this is a very durable, long-lasting repair in the appropriate patients. Dr. Syracuse, who I think is here, while at Columbia Presbyterian and Cornell, he looked at some of the data there for endarterectomies during using the NSQIP data, and he found 1.5% perioperative mortality, and obviously there's some very sick patients in here, and again about a 7 to 8% major and minor complication rate combined. And then here, the majority of the complications were infection. You make an incision, there's always a risk of infection. And that's where the vast majority of all the complications came from. If you look now going to Bellato and his study, they had 121 limbs treated, again from 2000 to 2007, no mortality, no major complication rate, and a 6% minor complication rate, 7-year patency of 96%, and primary assisted patency of 100%, limb salvage of 100%. So very durable procedure that lasts years, not months as we go through it. Kaplan-Meier looking at primary and primary assisted patency, going 96% primary patency, primary assisted to 100. And then you have to look at freedom from any intervention. So obviously these patients are vascular paths, so they can have SFA or iliac interventions down the road, and survival rate also is decreased again because of their comorbid conditions. It's a gold standard I think we have to compare to, and again the mortality rate can go into the 1.5% range, but most of these things are done in very high-risk patients with excellent outcomes. Complication rate between 5 and 10, most of them are, as I mentioned, secondary to wound infection, and long-term patency, again, above 90% primary patency. You come in now, and then we've already discussed, so I'll skip through some of this. The use of endovascular therapy, angioplasty alone does not work well. Now that does not include shockwave, does not include DCB, but plain old balloon angioplasty tends to have, as Dr. Schneider pointed out, significant recoil and is not a long-lasting procedure. So then you have to go to scaffolding, and I think there's many issues with scaffolding, especially if you're trying to use balloon expander or nitinol-based scaffolds. Patency's primary patency within the angioplasty with scaffolding group is in the 70 percentile range, 5-year in the 46 percentile range. So much, much different than endarterectomy. And again, this is showing the long-term graphs as you go to Kaplan-Meier, and again, they fall off significantly when you get beyond year 2. And then if you look at the ones for primary and secondary patency, again, it's falling off as well as increasing major adverse events over time as you get beyond year 2. So again, you have to look at these interventions not 1, 6, 12 months, but going out 2, 5, 10 years, which we see with endarterectomy. And then finally, again, Dr. Mehta showed his study of 167 limbs, and he tried angioplasty alone. Again, found that was not effective atherectomy in 22% of the cases, and stenting after failure of atherectomy in 9%. And he had a peri-procedural mortality of 0.6%, 1 out of 167. He had one pseudoaneurysm, one thrombosis, and one distal embolization. So very good technical result within this study. And then his long-term follow-up again showed that if they end up with combination therapy, they actually did better as they came through it, but still atherectomy did better than angioplasty alone. And this was mainly directional atherectomy. And Dr. Syracuse, again, with another trial, looking at the VQI database, and now has over 1,000 patients that he looked at in this series, and found that, again, the majority of these were done with angioplasty alone, a quarter with stenting. The covered stent grafts in 2%, and atherectomy in about 20%. A 4% technical failure rate, residual stenosis, and reported residual stenosis of 4.8%, which I think is probably a low figure as we've seen. Mortality about 1.6% for endovascular therapy. Primary patency at 1 year, 83%. Amputation-free survival at 1 year, 93%. And basically, he wasn't seeing that much difference in patency at 1 year between angioplasty and stent, angioplasty alone, and stent alone. And here's his life table analysis, looking at this for need for reintervention and patency and amputation-free survival. He found that as you went into a more significant disease process, the claudicants tended to do fairly well, but once you got into CLI with rest pain and tissue loss, they tended to continue to have issues as you went out to about 1 year. And then you have the overall patients with severe CLI with tissue loss ended up having to have reintervention in at least 30% of the time. So we talked about other interventions, and this is something I found to be very effective. It was originally thoroughly discussed by the Mayo Group, and this was back in 2011, of doing a femoral endarterectomy and then doing an iliac intervention instead of doing the standard aorta bifemoral bypass graft. And I think this is something where you're taking a low morbidity procedure such as a femoral endarterectomy, comparing it to a much more complex and much higher morbidity and mortality doing an aorta bifemoral bypass, and showed that by doing combination therapy of femoral endarterectomy, then iliac intervention, they got results that were very similar to that of aorta femoral bypass grafting. So again, I think there's a role for femoral endarterectomy alone, but also as a hybrid procedure with endovascular therapy too. So in conclusion, I think endarterectomy is still should be considered the gold standard that all other therapy needs to be compared to. I don't say it's never going to be replaced, but I think we need to be looking at this type of 7 to 10 year high, 90+% patency rates for endarterectomy. It can be effectively used in association with endovascular procedures for complex aortic occlusive disease. Angioplasty alone has the highest recurrence rate and does not negate, but it does not negate or complicate potential further open or endovascular procedures. Stenting has a better patency rate going up to a year or so, but does make further intervention more complex. And of course, as we mentioned, can result in jailing or occluding the profundifemoral. And the atherectomy, generally the directional atherectomy, can result in long-term patency, but does have an increased risk of embolization. But it does not impact further intervention. So I appreciate you allowing me the opportunity to discuss this, and I hope you consider both options as you're considering your care for your patients. Thank you very much.